It was the biggest healthcare fraud takedown in American history. $14.6 billion, 300 people charged. Then Congress asked the states one simple question: how did it ever get this big? Here's the hearing, then the full breakdown.
Director Sadwith, California has a large Medicaid program, spending more than $4.7 billion in 2025 on home and community-based services alone. Fraud in these services, as you would recognize, is a serious matter. In some cases across the country, patients have died when fraudsters bill Medicaid for services that were needed but never provided. Your office has stated in correspondence with this committee and CMS that California goes beyond federal requirements for providing screening and enrollment. If that is the case, why has your Medicaid agency classified all Medicaid-only providers as limited risk, a classification that comes with less stringent oversight standards? Do all of California's Medicaid providers being considered as limited risk really reflect what you're seeing in these programs?
Thank you, Chairman, for the question, and thank you again for the opportunity to be here today. Home and community-based services are a vital program in California. We know, for example, that they're cost-effective, reflecting a prudent use of taxpayer dollars. 1 year of receiving in-home supportive services saves federal and state taxpayer dollars approximately $100,000 compared to a stay in a nursing facility. And we are absolutely committed to ensuring the integrity of these vital services.
But by classifying all Medicaid-only programs as limited risk, are you seeing that all of these programs really show the limited risk as far as fraud goes?
Thank you for the question. So the risk classification, categorical risk level classification, is one of many tools that we use to assess program risk.
Is this adequate? When you paint with one brush all of those as limited risk, which requires less oversight, are you missing fraud?
We employ a number of safeguards to prevent bad actors from entering the program. For in-home supportive services specifically, we do conduct fingerprint and criminal background checks, which is one of the features of a high-risk categorical level designation. So even though—
But that's high risk, but we're talking about limited risk, which you ascribed to all Medicaid-only providers. Does that catch all the fraudsters, or should this be more of an individualized approach and not painting just with one brush? Is there an opportunity to really weed out the fraud at its beginning stages?
I absolutely share your focus.
Have you previously designated any Medicaid-only provider types that were classified as moderate or high risk?
To my knowledge, we have not classified any Medicaid-only provider types. We have gone above and beyond, historically, the federally designated risk
In
levels.
California, are you reassessing any provider risk designations in the state?
Thank you. We are actively assessing opportunities to strengthen program integrity in key areas. This includes, but is not limited to, the categorical risk level designation. We do have other tools that we use to go after higher risk areas. We have developed provider risk profilers for services such as hospice care, such as dental care, and other areas that are on our radar that we use in conjunction with comprehensive—
Okay, Sheila, you brought into this conversation now home health and hospices. Am I correct that California license home health and hospices before they can operate in the state?
Thank you for the question. This is a really important issue that I'm happy to talk about. It's really important.
Please do.
Yeah, the partnership between the state of California and the federal government is paramount to making sure bad actors stay out of the program when it comes to hospice care and home health. Just as context, Medicare, the federal program, is the primary payer for hospice care in California. The State Department, California Department of Public Health, my sister state agency, does perform licensure for hospice providers. And the state has acted swiftly to root out bad actors.
So before they can operate in California, this is just a simple yes, no. Do you allow this hospice organization to operate with or without a California license? Is that required before they can operate in California? Yes or no?
The California Department of Public Health has imposed a licensure moratorium that was enacted in 2021, and just this week implemented new regulations strengthening the standards for licensure for providers to be able to obtain a
So
hospice
prior to
license.
just this week, your words, you could operate a hospice in California without a license. Is that what you just said to me?
Pardon me, I respectfully disagree with the framing. I'm actually not an expert on that specific.
Okay, so let's move on. Director Basiri, personal care and home health aides are the largest and fastest growing job category in New York, and according to CMS, accounted for more than $44 billion in total payments between 2023 and 2025. I understand, based on information that New York provided to the committee just yesterday, even though it was requested in March, that New York State Department of Health is in the process of designating waivered personal care services as a high-risk program. Given that CDPAP, which is a self-directed personal care service waiver program, is provided in private homes with minimal oversight, what safeguards currently exist to verify the services are billed actually and delivered?
Thank you for the question, Chairman.
I'm going to ask you, my time has expired, I'm going to ask you to respond to that in writing. And with that, I will yield to the ranking member for her 5 minutes of questioning.
Thank you very much, Mr. Chair.
For 5 minutes of questioning.
Thank you. So first, for Director Basiri, New York has failed to provide certain information in response to the committee's letter. For example, you've not provided simple information such as all the states' designated risk levels for Medicaid-only providers types. Also note that you only provided the basic information that was requested about the frequency of on-site visits and yearly improper payment and recovery efforts the day before. Why have you been unable to provide that information to the committee?
Thank you for the question, Chairman. We have been as responsive as we can. We're handling many inquiries from both the committee, the Center for Medicare and Medicaid Services, and HHS OIG. But I'm happy to take that back, and we will.
We brought this up to you on March the 3rd. It's now June 25th. And if your agency doesn't have this information readily accessible, that's a problem in itself. But the committee and the American people deserve to have transparency of how New York and all states are operating in their program. And will you commit to providing that information to this committee that we've requested?
Thank you for the follow-up. We agree that transparency is paramount. I can't commit to that here, but I'm happy to take that back and get back to you as soon as possible.
You can't commit to providing just the information I just laid out?
I think I'm happy to take that back and get back to you.
Well, thank you. So Director Sadwith, kind of same committee requested documents information from your agency on March 3rd, including all audits related to fraud, waste, and abuse in the state's Medicaid programs, including audits completed by third-party contract auditors from January 1st, 2021 to present. I think that's about the time you said the licensing was ceased. I might have said in-home. I think it was hospice care when I was referring earlier. Based on the information that has been provided to the committee, we know that California has conducted such audits, but the committee did not receive a single audit document from California until 7 p.m. last night. Do you believe that providing more than 1,300 pages of documents on the eve of a hearing is fair to this committee?
Thank you, Chairman, and I acknowledge the frustration. We have been working with committee staff to produce information and address the questions, including the list of 26,000 audits and investigations that we have conducted over the past 5 years. Last night, we provided some audits related to transportation and mental health that the committee had indicated were of
Well, there are also others that we've requested. Will you commit to providing that, what we've requested to this committee in a timely manner?
Thank you, Chairman. There are ongoing law enforcement investigations that would be impacted by those specific audits that were requested. We're happy to provide the appropriate information at the appropriate time.
Well, let me say, it just seems unfair to us and then to prepare for a hearing that you send everything at 7 p.m. last night. It almost seems like that was intentional. It appears that way. So, Temporary Commissioner Connolly, the Early Intensive Development Behavioral Intervention Program, which provides autism therapy services in Minnesota, is currently experiencing unprecedented levels of fraud, exemplified by a recent fraud takedown in Minnesota charged by DOJ totaling $46.6 million, one of the largest in history. In this scheme, it is alleged that the defendants paid kickbacks to parents to bring their children to autism centers where children were diagnosed with autism regardless of the medical necessity. What are you doing to restore the early intensive development and behavioral intervention program to provide these services to those who it's intended for?
Thank you, Chairman Guthrie, for the question. So we are engaged in a number of efforts related to the autism services benefit in Minnesota, and certainly significant fraud happened, and I am not here to minimize that. However, as the fraud became apparent to us based on the information we were able to collect through investigations and through data analytics, we took a number of actions. I think one of the first was in October of 2024. Our staff did an on-site audit of all autism service providers in the program across the state. Later, it was designated as a high-risk service, so that comes with enhanced fingerprint background checks, unannounced site visits, a more frequent revalidation. Those providers are also included in the revalidation of 5,600 providers that I described in my opening comments. We also implemented, pursuant to the direction of the legislature, a new licensing framework for autism service providers. That is being implemented now. It's being phased in. We have a provisional licensure framework that providers, the vast majority of providers have applied for, and then full licensure will come into place in 2027.
Well, thank you. My time is running out. I just want to say, you said significant fraud was been committed, and you're not denying that or downplaying that. I think that's the word you said, which I appreciate that. I think hopefully all of you would admit to that. And my wish is that in a bipartisan way, all of us on here, instead of, well, the administration did this and fraud and whatever, there's significant fraud in the programs that not just the four of you are representing. I think if you look across, I don't know I'm not going to say every state because I don't know that, but I think it's absolutely significant. And it just seems like this is one thing we could all agree that we should fight the fraud of significant levels. You said significance, the word that you use. And I want to ask you, my time's now up, but I think this is just something that's frustrating that this isn't a bipartisan effort to root out fraud. I'll yield back.
The gentleman yields. The chair now recognizes the ranking member of the committee, Mr. Questioning.
My first three questions are a yes or no answer. You do not have to thank me for the question. Given that providers engaged in fraud, waste, and abuse that may involve being enrolled in both Medicare and Medicaid, does your state share information between the two programs to prevent enrollment of bad actors, Mr. Connolly?
I'm sorry, could you, are we sharing information with the Medicare program?
To ensure that you don't have fraudulent dual enrollment, Medicare and Medicaid.
We are sharing information weekly with the Centers for
yes
Medicare and
no?
Medicaid Services.
It's a yes. Mr. Sadworth?
Yes, we share information with CMS.
Mr. Becerri?
Yes, we share.
Mr. Patrica?
Yes, sir.
Okay, does your state share information with the Treasury's do not pay system or other federal databases? Mr. Connolly?
I'm sorry, could you repeat the question?
I know I have a southern accent. I'll try to speak a little clearly. Does your state share this information with the Treasury's do not pay system?
I'd have to confirm whether or not
Okay,
we've done
Mr.
that.
Sadworth?
Our state collaborates with CMS to share tax information.
Sounds like you don't even know what I'm talking about. Mr. Becerri?
I am happy to take that back and confirm.
Okay, find out. Mr. Patrica?
I'm sorry, sir. I'll have to provide follow-up on that question.
Okay. Does your state work to share this information across state lines to ensure that you don't have people enrolled in your states that are enrolled in other states? Mr. Connolly?
Yes, that is part of a regular
Thank you.
exercise.
Mr. Sadworth?
We share information on eligibility that is.
It sounds like you don't know Mr. Becerri.
We do
Thank
to
you.
the extent
Mr. Patrica?
I apologize, sir. I'd have to confirm that we,
Okay,
we
thank you.
share with CMS.
Mr. Connolly? CMS asked that you revalidate all providers in the 14 high-risk Medicaid programs. It's nearly 5,600 providers. After the initial revalidation, your office reported it disenrolled more than 3,400 providers. That's 60% of those enrolled. However, last week, it appears your agency restored the billing privileges for over 2,100 that submitted the appeals. What's going on with this revalidation process, and how are you making sure that providers were restored pending appeal or filing legitimate claims in the meantime?
To preserve continuity of service for the beneficiaries,
But what are you doing to make sure that they're not filing illegitimate claims?
all of those services are subject to enhanced prepayment review. and all of the high-risk designation requirements that are associated with it.
Of the 3,400 providers who were initially disenrolled, when were those providers last revalidated? Was it within the last 5 years?
Yes, all providers have to revalidate within 5 years.
It's also been reported that many of the providers that were disenrolled had been flagged by your agency before. Is that true?
I'm sorry, could you repeat the question?
It's also been reported that many of the providers that were disenrolled had been flagged by your agency before. In other words, there was some suspicion. Is that true? Had they been flagged before?
I'd have to confirm the details of that for you.
All right. Did your agency ascertain whether the providers that were disenrolled, when re-enrolled pending appeal, were providers that had been previously flagged for fraud?
Providers that are flagged for fraud have a payment withhold applied and are sent, those cases are sent to law enforcement.
So you're saying that none of the ones that have had their billing privileges restored were flagged for fraud in the past?
If we are aware, our Inspector General is aware of a credible allegation of fraud, there would be a payment withhold and they would be referred to law enforcement for investigation and prosecution.
Can you confirm that your agency is conducting this validation in a thorough manner and that no providers being revalidated are fraudulent or have been flagged as potentially fraudulent?
Our team is being very exacting, making sure that providers meet all the compliance requirements.
The thing I want to make certain here is that none of us on this side of the aisle want to deny services to anybody who legitimately needs it. What this is really about is that there have been billions of dollars stolen from state and federal programs that should have gone to help people who legitimately need them. That's the shame of this. That's the tragedy of this, is that there are people who need these services that are having to have limited compensation, limited access because so much money has been stolen. That's what this is about. And that's why we're going to get to the bottom of it, correct it, so that the people who should be getting the funding for these services get what they're supposed to get. I yield back.
The gentleman yields. The chair now recognizes Mr. Tonko for his 5 minutes of questioning.
Well, I appreciate that, Chairman, and I think there is a lot of fraud in these states at local levels, and my attention goes to Mr. Partika from Ohio. I also want to thank Keith Faber from Ohio for actively investigating discrepancies that we found implemented in the Medicaid expansion program of the state of Ohio. HCBS services allow seniors in the state of Ohio with disabilities to receive care at home rather than an institution. This is on the core, a beautiful thing where we could have a family member stay at home and take care of their loved ones, which is everyone's ideal situation. The problem that we find out is sometimes you have 3 or 4 family members that are all staying at home, and the family's bringing $150,000 or $200,000 of money to that family by them all staying at home and doing nothing. The program wasn't built for that, and that's not what it was supposed to be about. However, fraud diverts resources away from patients who truly need that care. And in Ohio, when I was a state senator, Ohio's 4th in the country for Medicaid expansion. We have a $93 billion budget in the state of Ohio, which is every bipartisan, which is every 2 years that it runs on $93 billion, and we're using almost half of that for Medicaid expansion. In Ohio, we correct our wrongs. I saw Governor Walz, whose state is the #1 worst fraud in the entire country, gallivanting all over the country, trying to attack Republicans. When he was at home, he should have been at home correcting this fraud. So my question to you, Director, is I know that your administration has already been working. Can you go through some of the fraud that you already discovered? And more importantly than that, can you go through the fraud that you think you might find?
Congressman, thank you for the question, and we share at Medicaid your sentiment towards the meaningful intent of many of these programs, which is why we fight anyone defrauding them, insulting, and needing addressed so that we can provide that long-term stability. As we talked about in the home health space, we've identified abnormal trends in different parts of our state, abnormal billing patterns that we are now working to address. We have identified and has been in the news the $42 million finding on the behavioral health services provided in our community that we've been working on making policy changes, including prior authorizations, reviewing our enrollment process, and identifying high-risk providers in each of those areas. The critical challenge as we do this work moving forward is making sure we are doing it in a way that is responsible and it does not punish the hardworking providers that are doing it the right way each and every day, so we could fulfill that commitment to provide those services to those that are truly intended in needing that care.
What was exciting for me, Director, is when I realized that we had the Attorney General and we had the auditor working with your office. Because you know what? In life, sometimes we're not perfect. And the wonderful story about America is and you look at our history, we correct our wrongs like we do in Ohio. So we're not all full of ourselves that says that we're perfect in the state of Ohio. We know that we're flawed. But I like the idea that the three branches over there, you got the Attorney General's office, you got the Ohio Auditor, and then you have you that are all working together to make it better. When you're fourth in the country for Medicaid expansion, we want to make sure that our people have their services. Now, in the next year or two, how do you think this partnership that you have with the Attorney General's office and the Auditor's office is going to look like? Do you think we're going to really be able to get down into the nitty-gritty and even get a lot more fraud in the next 6 months, the next 2 years? How do you think this is all going to play out with that union of your three different branches helping each other?
Congressman, as you stated, that partnership over the years spanning multiple administrations has been incredibly valuable. Many of the findings the auditor has had have directly correlated improvements to the Medicaid program. I expect that to continue. The work with our Attorney General and our new Attorney General, Andy Wilson, I expect to be incredibly powerful. As the teams work together, the newfound partnership of not just looking at each individual case and where we're identifying trends to identify new investigations, but bringing that back to our team and saying, here are potential risks from a policy standpoint in the administration of that program. I'm incredibly hopeful that we continue to make improvements moving forward, much thanks to that expertise that those multiple teams bring.
I really appreciate it. And it gets exciting thinking that when we discover something like that and just saying how horrific it is, when we can look at the future and preserve these wonderful institutions, like when you have a Medicaid or Medicare or even Social Security, if we're able to find this fraud, we will preserve these so they can last for generations for our grandkids and our great-grandkids. I appreciate all the work you do for the fine state of Ohio. And with that, I yield my time, Chairman.
The gentleman yields. The chair now recognizes the gentleman from California, Mr. Questioning.
Thank you, Chairman, and thank you for being here today and informing us on what in the world how this took place. The first question I have, I think all of you have admitted that you have significant waste, fraud, and abuse in these programs in your states. Is that correct? Would anyone dispute that? I think the question here is, should taxpayers continue to pay and be put on the line for this waste, fraud, and abuse, or should the taxpayers say, okay, you fix it, and then we'll be glad to fund those who, by law, are allowed to use these programs? That's the question, and that's the difference of opinion here, in my mind. For all the witnesses, ongoing criminal investigations in many states have identified shared ownership or affiliations where individuals are enrolled in perpetrating fraud in numerous Medicaid services. What exactly is your state doing to more closely examine currently enrolled Medicaid providers to identify shared ownership or affiliations with excluded providers that have previously perpetrated fraud? That is your responsibility. Tell me what you're doing there. And I'll start with Mr. Connolly.
Thank you, Representative Allen. So the first thing I would point out is that fraud is unacceptable. We agree with that. And we have fought very hard to root out fraud in our programs with respect to different steps taken to find connections among bad actors or criminals in our program, whom we hope are prosecuted and go to prison because of the fraud they're committing. We have initiated, of course, the revalidation effort among the high-risk providers that we designated. So 14 services, as I said, were designated high risk. They were all subject to that revalidation, that off-cycle revalidation that I mentioned, the 5,600. And part of that work is to identify through the fingerprint background check, through the site visit and the review of credentials and documentation, who those providers are led by, what ownership is, and do analysis with the appropriate databases and work with law enforcement to understand what connections there may be among bad actors and criminals.
Yeah.
So we are taking that action, I think, principally,
Okay.
but also we do
Yeah,
work with
I
federal and
got-
state law enforcement.
I got 3 more I need to get to, so if we can make our answers short. And I'm going to have a follow-up question as well, are there any elected political officials in your state that are doing everything they can do to keep you from uncovering this fraud, waste, and abuse? And of course, now I'll go to the next witness. Yes.
Thank you. So to address your first question, fighting fraud is a top priority for our department, and we know fraud is not unique to Medicaid or even Medicare. It's also in private health insurance, and that's why we have to work together to protect taxpayer dollars. Making sure that we crack down on bad actors who have, use business structuring to conceal their illicit activity is a top priority for California. We collect comprehensive disclosure, ownership, and control interest information from every provider applying. We check those against federal and state exclusionary database lists. We also check those lists for subcontractors of those providers and other business entities that they have a significant business relationship with.
Is it, okay, Mr. Becerra?
Thank you for the question, Congressman. And last year, under Governor Hochul's leadership, we really prioritized the development and implementation of a provider services portal, which is a new provider enrollment system, and putting that in place. It is slowly rolling out now, and as part of the revalidation plan being requested by CMS, we are sort of expediting that implementation plan. We are adding new Medicaid-only providers to high-risk designations and pursuing moratoriums where applicable. We completely agree that the front door to the program is a very important safeguard.
Good. Mr.
Yes, Congressman, in Ohio, when we've identified shared ownership, after indictment of fraud, we will take action. Recent improvements have helped that. As folks continue to conceal their ownership and control of entities, that is a challenge that I think states and federal government will be tasked with.
And yes or no, this all happened in the last year? When this was brought to the public eye, it's been a year. And my question is, did the Biden administration notify you of any of these issues when they were in charge of CMS? Did you get any requests for them for identification of waste, fraud, and abuse?
These processes have been in place in California. They're not new. And yes, we did collaborate with the Center for Program Integrity at CMS.
But it was not publicly known at that time, I don't believe. Is that correct? Okay, well, I'm out of time, and I'll yield back, Mr. Chairman.
The gentleman yields. The chair now recognizes Ms. Trahan for her 5 minutes of questioning.
Thank you, Mr. Chairman, and thank you all.
Republicans' big ugly bill cut health care by $1 trillion, and then the Trump administration launched a campaign to cut health care to blue states even more. On February 26, just 2 days before Trump began his reckless war of choice with Iran, Vice President Vance announced a deferral of $250 million in Medicaid funding to Minnesota. So I want to ask Dr. Connolly, actually I'm going to go to each of the 3 state representatives, so if you could just respond in a minute or so. So Dr. Connolly, you've described the deferral as a, quote, catastrophic funding loss for Minnesota and the children, families, and seniors that rely on the program. So what does an unprecedented deferral of this size mean for Minnesota children and families, and has CMS given you any indication of whether these deferred payments will be released or when?
So the size of both the deferrals, which are roughly $350 million, on top of the $2 billion roughly annual withholding associated with CMS's compliance action, that is a significant amount of money when the entire program is roughly $20 billion in entire federal and state spend. So that is a very large sum of money that threatens the state's ability to finance the services and benefits that are part of the program. In addition, we have a structural budget deficit in Minnesota. We've had that for a couple of years now, and so we are already struggling to maintain the services, the payment levels for providers across the state, the eligibility levels that we have in the program. So this adds another layer of pressure and risk to those realities. With respect to CMS and us working with them, we have done everything since December 5th and the notification that they were requiring a corrective action plan of us that they have asked. We've revised it once, provided that timely on time, and have implemented every step and milestone in that corrective action plan since we submitted it.
Any indication of whether these payments will be released or when? I'm just trying to move on.
None yet. Representative Pallone, thank you.
I appreciate it. I'm just trying to get all of you in. In California, CMS has targeted home and community-based services, or HCBs. Cuts to HCBs mean Medicaid recipients will end up in institutions rather than get care in their homes or receive no care at all, possibly. So, Mr. Sadowitz, if HCBs are cut and patients are forced into institutions, what are the consequences for patients, their families, and taxpayers? In about a minute, if you don't mind.
Thank you for the question, Representative. So I'd like to take a minute just to talk about what these services are and who's receiving them, to put a human face on them. So in-home supportive services are provided to some of California's most vulnerable residents, including children with disabilities, adults with disabilities, and seniors who cannot live safely at home. All in-home supportive services recipients meet institutional level of care, which means that they qualify to be admitted and to live in facilities and in institutions. IHSS services assist people with living safely at home. These services include things like helping with bathing, with grooming, with hygiene, with meal preparation, and paramedical supports such as changing colostomy bags, injections, medication administration, and driving recipients to doctor's appointments. So without these services, children would be living in facilities, and adults and seniors would also be living in facilities. And these are also cost-effective services. It's a good use of taxpayer dollars to invest in these services. Every year that we provide in-home supportive services and keep someone out of a nursing facility, we save state and federal taxpayers approximately $100,000.
I appreciate it. And institutionalization is not only terrible, but costs so much more money. So, Mr. Basiri, you've said the effects of paperwork requirements could be, quote, catastrophic for New York. What impact will these requirements have on patients and providers in New York's Medicaid program? And you've only got about 45 seconds to answer.
Thank you for the question, Ranking Member Pallone. I believe you're referring to the implementation of community engagement requirements, which we are set to do on January 1st of this year. I think the biggest challenge is communicating effectively and accurately with our members about the changes that are forthcoming and the varied nature of those changes at different time periods. We are incurring about a 20% increase in administrative costs to accommodate some of the implementation requirements to mitigate from consumers, but we are taking proactive steps to make sure we're making sure people are aware of the changes. We don't want any disruptions in continuity of care, and that's where our focus has been.
Thank you. Thank you, Mr. Chairman. Yield back.
The gentleman yields. The chair now recognizes the vice chairman of the subcommittee questioning.
Thank you, Mr. Chairman. I'm late because of science, space, and technology. We had a markup that I had to participate in. I walked in on a bunch of claims from our colleagues across the aisle there. Mr. Chairman, it's not that they're ignorant. It's just that so much of what they know ain't so. So let me go to you, Mr. Connolly. Thank you for your testimony. The level of fraud that has been unearthed in Minnesota's Medicaid program is alarming. In what ways is the Department of Human Services revising the state's previous Medicaid provider enrollment process for new providers in the 14 high-risk programs to improve provider screening going forward?
Thank you, Representative Weber. And we agree the fraud that has occurred is unacceptable, and that's why we worked hard on provider enrollment and compliance. Directly to your question, we have designated 14 services as high risk, 13 remaining, and part of that involves provider enrollment and compliance action that is escalated. So there's an unannounced site visit that could occur, that does occur rather, in addition to a fingerprint background check and more frequent revalidations. And all of those providers have been revalidated within the past 5 months as well, in partnership in completing that corrective action plan at the direction of CMS.
So these are targets, these 14 services were targets for the fraudsters. Is that low-hanging fruit? Why do you think that is?
Could you repeat the question one more time?
These 14 services were targets for the fraudsters. Is that because of low-hanging fruit? We're not paying enough attention? What do you think? Why do you think that is?
Thank you for the question, Representative Weber. So I think it's for a variety of reasons, and we've demonstrated in our actions what we think those reasons were. So it starts with the design and the policy around the program. So are there different requirements that need to be escalated? New billing parameters, for example. We implemented enhanced prepayment review to vet claims before they go out to providers so we don't pay and then have to recover if there's fraud. We also do post-payment activity, often in the form of investigations. We have data analytics that also inform referrals to our Inspector General for investigation. And then, of course, if those cases rise to the level of a credible allegation of fraud, we then refer promptly to federal and state law enforcement for further investigation and prosecution if they deem that necessary.
Do you keep a list of all the fraudsters and their procedures so that you can recognize that going forward?
Yes, as a part of our investigations, we have a list of all of the providers that have risen to the level of a credible allegation of fraud, and certainly we're paying attention to any announcement of charges with respect to law enforcement. So we do look at the behaviors and the different things that we found in terms of how they've billed and behaved, and we do keep that intelligence.
So if there's any cracks in our walls, you're able to go back and fix those cracks?
Yes, exactly. So if there is a pattern or a concerning issue that we identify, that does inform perhaps administrative changes in policy. We might also engage legislators to make changes to those programs, which we've done in the last 2 sessions as a good example.
All right, thank you for that. Mr. Is it Sadwith? Is that how that's said?
Yes, sir, Sadwith.
Okay, have you had that name long?
Excuse me,
I'm
sir?
just messing with you. Your written testimony highlights that Medi-Cal has, quote, strong policies that are designed to prevent, identify, and block the fraud, waste, and abuse we were just talking about. Below this, your testimony cites that California's Medicaid Fraud Control Unit, MFCU, received 700 credible fraud allegations over the last 5 years. While fraudulent hospice billing in Los Angeles County alone is estimated at $3.5 billion with a B dollars. That accounts for 18% of all national hospice billing. Would you say California's MCFU was effective in preventing that abuse?
Thank you for the question. And this is an incredibly important issue, and it underscores the need for collaboration, continued collaboration between states and the federal government. In California, the primary payer for hospice care is Medicare. In Medicaid, which the Medicaid Fraud Control Unit sort of prosecutes, we've referred over 300 credible allegations of fraud to the MFUCU over the past 5 years for the purposes of investigating and cracking down on hospice fraud in the Medi-Cal program, the state program that I oversee. But that's why it's important to work in partnership with the federal government and CMS, which is responsible for oversight of Medicare.
Yeah, but you said 300, and I cited 700. That's not even a 50% of success rate, is it?
So we view the 300 referrals as a strong commitment to California's rooting out bad actors in our Medicaid program. And we, just like Medicare and CMS, we have experienced issues in hospice and have taken comprehensive steps to protect the program, protect the Medicaid program, through new requirements and new safeguards, and institute licensure moratoriums, institute new regulations. We've criminally charged over 100 individuals in the past few years. We've stood up a statewide hospice task force. We've revoked over 300 licenses, and we have over 300 licenses that are ongoing.
Well, I'm going to have to yield back, but I insist that's a little short of the target. I yield back, Mr. Chairman.
The gentleman yields. The chair now recognizes the gentleman from Ohio, Mr. Landsman.
Validate whether encounter data submitted by managed care organizations accurately reflects actual payment made to providers. And we'll start again with Director Sadwith, please.
Thank you, Representative. So we have a number of processes in place to validate managed care encounter data, both internal processes as well as processes in place with external entities.
Thank you. Director Braceri.
We have several mechanisms in place, including state laws and penalty programs to ensure completeness and accuracy of our managed care encounter data, and we use that encounter data for as much in rate setting as the actuary will allow.
Very good. And Commissioner Conley.
Similarly, we have very complete claims data from managed care plans that we use to analyze trends and different issues with those claims.
Very good. Another question, follow-up question. If managed care payments are excluded from RAC audits, how are you independently validating the accuracy of those payments? And again, you touched on it, but let's elaborate if possible. If you don't mind, we'll start with Director Sadowitz.
Thank you, Congressman. So we do have a number of processes in place to validate the accuracy and completeness of encounter data. We have been working with plans to sort of increase the rate to which encounter data are incorporated in managed care rate setting processes. And we have a stoplight program that provides feedback and corrective action plans to improve their managed care encounter data submissions. This is an ongoing process that's absolutely key to quality measurement, to data accuracy, and to rate setting.
Very good. Director Borsari.
In addition to what I mentioned before with the statute and penalty programs to ensure compliance, we have our Medicaid model contract has a number of provisions around third-party liability, and our Office of Medicaid Inspector General works very closely with the plans to ensure appropriate coordination of benefits.
Thank you. Commissioner Conley.
Thank you. Similarly, we have requirements with respect to claims and data collection from the plans. Our Inspector General also works very closely with the plans and their program integrity staff to follow up on credible allegations of fraud.
Thank you very much. I have a question for Director Partika, but I'll submit it for the record. I appreciate it. I'll yield back, Mr. Chairman. Thanks for giving me the extra time.
The gentleman yields. Seeing there are no further members with...
Let's break down a long House Energy and Commerce hearing on Medicaid, the health program that covers low-income Americans. 8 members questioned a panel of state officials, and it was really 2 arguments in one room. One side was hunting for waste and fraud in the program. The other side was defending the coverage the program provides. Both point to something real. Here's the split. The Republican members focused on improper payments, weak provider screening, and specific fraud cases in states like California, New York, and Minnesota. The Democratic members focused on what happens to patients when the program is squeezed and warned that a fraud crackdown can become a cover for cutting coverage. A fair check has to weigh both. And there's one distinction that decides almost everything in this hearing, so we'll put it front and center: the difference between fraud and paperwork. They're not the same thing, and mixing them up is where most of the heat came from. One ground rule before we start. A fact check isn't about which party you like. It's about checking each claim against the record, the audits, the fraud cases, and the official numbers. Some claims from both sides hold up. Some are stretched. We'll take them one at a time. Start with the scale, because it explains why everyone in the room cared. Here's the anchor. Medicaid covers more than 80 million Americans and costs somewhere around $900 billion a year across federal and state budgets. A program that large will always have errors and always attract fraud simply because of its size. On that, both sides agree. So keep this in mind. Nobody at the hearing was for fraud. Nobody was against catching it. Both parties say waste in a program this size is worth chasing. The real disagreement is about how much of the problem is actual fraud and whether the proposed cures would hit criminals or ordinary patients. It also helps to know who the witnesses were. They were mostly state Medicaid officials, the people who actually run the program day to day. That's why so many questions were about documents, audits, and screening. The members were, in effect, auditing the auditors. Now, the number that got thrown around most, and the one most often misunderstood, the improper payment rate. Each year, the government reports a Medicaid improper payment rate, and it has run in the range of about 5% recently. That sounds alarming, and it's a real number. But here's the part that changes everything. The government itself says the large majority of it is not fraud. Here's what that money mostly is. An improper payment is any payment that lacked the right paperwork at the right time. That includes a missing signature, a late eligibility recheck, or a provider file that wasn't complete. In most cases, the person was actually eligible and the service was actually provided. The error is in the file, not in the care. So both readings of the number are technically available, and that's the trap. You can say improper payments are huge, which is true, or you can say very little of it is confirmed fraud, which is also true. An honest presentation says both in the same breath. Saying only one is how you mislead without technically lying. There was also a spike worth explaining. A few years back, the improper payment rate jumped much higher, and critics pointed to it as proof of chaos. The main cause was that routine eligibility checks were paused during the pandemic emergency, so the paperwork simply wasn't done on schedule. As those checks resumed, the rate came back down. Context matters. None of that means the paperwork doesn't matter. Sloppy documentation is a real problem. It hides the actual fraud inside the noise, and it wastes money rechecking files. The Republican members are right that tightening it up is worth doing. The overreach is only in calling all of it fraud. And there's a reason to take the program's oversight seriously. The Government Accountability Office, the nonpartisan watchdog, has kept Medicaid on its high-risk list for years, precisely because of its size and the difficulty of tracking every dollar across 50 states. So the concern is legitimate, even when a specific number is being spun. It helps to know how the number is even made. Auditors don't check every claim. They pull a sample, verify the paperwork, and scale it up to an estimate. That's a reasonable method, but it means the headline figure is an estimate of documentation problems, not a count of dollars a criminal walked away with. Treating an estimate as a cash total is a common mistake. There's one more honest wrinkle. A chunk of improper payments, once the missing document is finally produced, turn out to have been perfectly valid all along. In other words, some of the scary number evaporates on a second look. That doesn't excuse the sloppiness, but it's another reason the raw figure overstates true loss. Now the strongest part of the Republican case, because some of the fraud they pointed to is very real and very specific. Congressman John Joyce, a physician, pressed hardest on two things: how states screen providers and hospice. Here's the screening issue in plain terms. When a provider enrolls to bill Medicaid, they're sorted into risk categories, from limited to high, which sets how hard they get vetted. Joyce's point was that some providers who should get tougher scrutiny are being waved through as limited risk. Weak screening at the front door is how bad actors get in. And hospice is a genuinely documented problem. Federal investigators have found rings of fraudulent hospice operators, heavily concentrated in a few states, that enroll people who aren't actually dying and bill the government for care. It got bad enough that regulators created special oversight programs for hospices in the worst-hit states. This one is not exaggerated. Congressman Randy Weber and others pointed to Minnesota and a set of cases that have become a national symbol of fraud. The Minnesota cases are serious and largely proven in court. Schemes tied to public programs, including a massive pandemic food aid fraud and fraud in autism and health services, siphoned off hundreds of millions of dollars. Prosecutors have won convictions. When members say the money was stolen, in these specific cases, they're right. But here's the fair caveat. Proving that specific criminals stole hundreds of millions is not the same as proving the whole program is rotten. Big fraud cases and a mostly functioning program can coexist. The honest lesson is that enforcement worked, the criminals got caught, and the system needs to catch them faster, not that every dollar is suspect. Congressman Rowley made a constructive version of the point, contrasting the Minnesota cases with his own state's fraud enforcement as a model. That's actually the useful frame. States run Medicaid differently, so the ones that catch fraud well become the blueprint for the ones that don't. The finger pointing is less valuable than copying what works. Congressman Rick Allen pressed the question that sits under the whole hearing. Should taxpayers keep paying full freight while a state is still fixing a known fraud problem? It's a fair thing to ask. The honest answer is that you can hold a state accountable without freezing the care its residents depend on. But the tension between those two is real, and it doesn't fully resolve. Chairman Brett Guthrie focused on the states themselves and their paperwork, New York and California, and late audit dumps. Guthrie's frustration was procedural but fair. When a state can't produce documents on time or delivers a flood of records right before a deadline, it makes real oversight almost impossible. You can't tell fraud from error if the paperwork never shows up. On the process, the chairman has a strong point. Congressman Gus Bilirakis raised the part of Medicaid that's hardest to audit at all: managed care. Here's why that matters. The large majority of Medicaid enrollees are now in managed care, where the state pays a private insurer, a flat amount per person to handle their care. That's efficient, but it moves a lot of the spending behind a private company's books, which makes payment accuracy harder to verify. Bilirakis was right to flag it as a blind spot. And the tool he pointed to, recovery audits, is a sensible one. These are contractors who review paid claims after the fact and claw back money that shouldn't have gone out. They don't prevent fraud up front, but they recover real dollars, and expanding them is one of the less controversial fixes on the table. Managed care also has its own quieter money question separate from outright fraud. States sometimes route extra dollars to hospitals and plans through complicated arrangements that are legal but hard to trace, and critics on both sides have questioned whether every one of them is justified. It's less a scandal than a transparency problem, and is exactly the kind of thing better audits are for. Now the other side of the room. Ranking Member Frank Pallone turned the focus from the fraud to the patients, and to what a crackdown can cost them. Pallone's central worry was a tool called a deferral. When the federal government suspects a state's paperwork is off, it can hold back or delay the federal share of the money. That pressures the state to fix its records, but if the state responds by tightening enrollment, real eligible patients can lose coverage while the paperwork gets sorted out. His deeper argument was about motive. He warned that the language of program integrity can be used as a polite way to shrink the program. If the real goal is to spend less on Medicaid, calling it a fraud crackdown makes the cut easier to sell. Whether that's the goal here is a judgment call, but the pattern is one worth watching. There's a recent concrete example behind his worry. When routine eligibility checks restarted after the pandemic, states rechecked everyone at once, and millions of people were dropped, a large share of them for procedural reasons, like a form that never reached them, not because they were actually ineligible. Many later re-enrolled. It's a live demonstration that paperwork crackdowns catch eligible people too. And there's a churn cost people forget. Every time an eligible person is dropped and has to re-enroll, the state spends money processing them twice, and the person may skip care or land in an emergency room in between. So an overly blunt crackdown doesn't just risk coverage, it can quietly cost money on both ends. Precision is cheaper than it looks. And here's the honest tension. Tighter checks catch more fraud, but they also catch more eligible people by mistake, because the same paperwork hurdle trips up criminals and confused enrollees alike. Loosen the checks and you miss fraud. Tighten them and you drop some real patients. There's no setting that's perfect, and pretending otherwise is how both sides oversell. Pallone also made a numbers point that lines up with the record. Because most improper payments are documentation, not theft, a crackdown aimed at the paperwork recovers far less actual stolen money than the headline number implies. So the savings from a fraud crusade are usually smaller than promised, while the coverage risk is real. The strongest version of his argument isn't that fraud doesn't matter. It's about aim. Go after the hospice rings and the organized schemes with everything you've got, because that's where the real money is. Just don't build a system so strict that a working single parent loses coverage over a missing form. Precision, not volume. And the temperature spiked in a couple of specific exchanges worth calling out fairly. Congressman Gary Palmer pressed the witnesses with rapid yes or no questions and said they sounded like they didn't know their own programs. It made for sharp television. The fair read is mixed. Some of the officials genuinely struggled to answer basic questions, which is a real problem, but yes or no format also strips out the context a complicated program actually needs. Congressman Randy Weber's exchanges got heated too, disputing the other side's characterization and pressing California on hospice. Under the drama, the substance was the same divide we've traced all along. Real fraud cases on one side, the risk to patients on the other. The volume changed. The underlying facts didn't. So let's total it up honestly on both sides of the room. On the fraud side, the hospice rings and the Minnesota schemes are real and proven. Screening and managed care oversight have genuine gaps, and states owe better paperwork. On the coverage side, most improper payments are documentation, not theft. Deferrals can hit real patients, and a crackdown saves less than advertised. Both sets of facts are true at once. None of this tells you how to vote. You can want aggressive prosecution of the hospice rings and also want a working parent to keep coverage through a paperwork mix-up. Those aren't opposites. The mistake is treating the hearing as one fight with one winner, when it was two real concerns pointed in different directions. Give each side its due. The integrity hawks are right that real fraud exists, that screening is too loose, and that some states hide behind bad paperwork. The coverage side is right that most of the improper payment number is not theft, and that a blunt crackdown drops eligible people. A viewer who holds both understands this better than one who only cheers a side. And notice the common ground, because it's bigger than it looked. Better provider screening, faster audits, and going hard after organized fraud rings draw support from both parties. Those steps cut real fraud without cutting real coverage. That's the narrow lane where this hearing could actually produce something useful. Remember, too, that Medicaid is really 50 programs. The federal government sets rules and pays most of the bill, but each state runs its own system, with its own paperwork and its own vendors. That structure is why one state can have a hospice fraud epidemic, while another barely does, and it's why a single national number hides a lot of very different local realities. And that structure points to the fairest fix. Instead of one blunt federal crackdown, target the specific states and specific schemes where the fraud actually is, and leave the well-run programs to keep covering people. It's slower and less dramatic than a headline number, but it's the version that catches criminals without punishing patients. So, where does it leave us? With a program big enough to have real fraud and real value at the same time, and a fight over whether we're aiming at the criminals or at the paperwork. A serious country can chase the fraud without dropping the patient, and this hearing is a good argument for why it has to. Watch 3 things from here, and the first is the number. Whether officials keep separating fraud from paperwork honestly, or whether the improper payment figure keeps getting sold as pure theft. That single distinction will tell you who's leveling with you. Second, the real cases. Whether the hospice rings and the organized schemes actually get shut down faster with better screening at the front end. That's the enforcement that recovers real money, and is the test of whether this was oversight or theater. And third, the patients. Whether tighter rules and deferrals quietly drop eligible people from coverage over paperwork. If the uninsured tick up in the states under the most pressure, that's the coverage cost the other side warned about arriving on schedule. Those answers will come on the record. The fraud won't vanish because we shouted at witnesses, and no patient gets protected because a hearing ran hot. The work is in the screening, the audits, and the coverage numbers, and that's where we'll keep watching. That is our breakdown. Stay with us.